Good afternoon, everybody, and welcome to today's webinar. We have Dr. McKenzie with us, and I will let him introduce himself. Dr. McKenzie.
All right. Greetings. This is Stroke Awareness Month, which I will say I'm actually a cardiologist, but there was a time when people would stay at home and basically die of a heart attack. And because of a very orchestrated, multimodal educational campaign over the course of probably 10 to 20 years, people in the community went from scratching their head and wondering if they were having indigestion or chest pain or something to immediately saying, could this be a heart attack? And also our educational interface with our colleagues in the emergency room, they also went from changing the diagnostic possibility for somebody with chest pain to wondering maybe it's a pulled muscle or this or that, to elevating, is it a heart attack, as the number one thing that needs to be excluded. So nowadays, we don't see people, staying at home and having extended heart attacks the way that we used to see that. And it's really a credit to a educational campaign that is run on a national level, of course, but it really at the grassroots level, it has its most impact on the community hospitals and regional hospitals, interfacing with patients and people in the community at large. So I'm a big fan of the idea of a Stroke Awareness Month, and I'm happy to be a part of this program, and hopefully we'll see the, I think stroke is where we were with heart attacks, 20 years ago. It's a new clinical syndrome, and there's a strong educational value in getting people to come in early to the emergency room if they're possibly having a stroke, because the treatments work better early. Now, rather than believe me, I have an infinite number of slides with all kinds of graphs and tables and p-values and data. But I thought I would actually do this talk more like a TED talk, where I'm just going to basically talk off the cuff here. And I've got a few models to show you when it comes to the show and tell part. So as I alluded to earlier, I'm a cardiologist, even though this is a stroke awareness talk. Why is that? Well, it turns out there are three main ways that a stroke occurs. A stroke in general involves depriving a part of the blood, a part of the brain, of its blood supply. And when the reduction in blood flow is after a certain period of time, then those nerve cells in the brain, because they don't get blood, they don't get oxygen, they stop working. And then it really depends on which part of the brain is being affected. If it's brain cells that lead to your vision, well, now you can't see. Or if it involves moving your arm, then your arm or your leg might be weak. So it depends on where in the brain the stroke is occurring. But the general physiology is all the same. It's a part of the brain tissue is being deprived of blood. If the blood is restored within a certain period of time, then there's no permanent stroke. That's called a TIA, transient ischemic episode or event. Transient TIA, A is for attack. But if the damage to the cell is permanent, then that becomes a infarct, is our medical term, but it's just basically a stroke. And so that gives you kind of a background. Now, there's three ways that blood flow can get blocked off from a artery going to a portion of the brain. One is you're very accustomed to thinking of is one of the arteries, either one of the large artery, the carotid, or one of the branches of the carotid develops plaque from cholesterol. And then this is the same type of disease which occurs in arteries of the heart. So the same plaque deposition from cholesterol, from the effects of diabetes and smoking, etc. And then this plaque, rather than a smooth lining of the inside that the blood vessels typically have, plaques are very sticky, so to speak. So they are prone to have elements in the blood called platelets, and then other aspects of the blood cause a thrombosis, which is occlusion. So the plaque can generate a occlusion of an artery, or pieces of the plaque can actually break off and go to tiny arteries. So plaque atherosclerosis is the medical term. And so that's one of the key mechanisms of stroke. Second one is uncontrolled high blood pressure, the effects of very high spiking of blood pressure inside the arteries of the brain. The tiny arteries start to thicken to protect themselves, and then ultimately they just close off. Okay, so that's uncontrolled high blood pressure. That's the second cause or mechanism. And then the third involves a blood clot from somewhere else in the body that finds its way into the blood vessels of the brain. So here, the arteries of the brain, they actually could be just fine. There could be no spiking of blood pressure. There could be no plaques, but a clot finds its way into the arteries, and it lodges there, and then that blocks off that artery, and the blood, the brain tissue that's supplied will then get damaged with a stroke. So now, where do these blood clots come from? They come from the heart over 90% of the time. Now, sometimes it can come from the leg, and then it can get through the heart up to the brain, but that's rare. So when we say blood clot as our third mechanism, then we pretty much mean a clot from the heart. And then 90% of the time, the cause for that blood clot to be formed is a heart rhythm problem, believe it or not. And the name of that heart rhythm is called atrial fibrillation. So I'm cutting corners a little bit. Of course, there's lots of rare causes for clots here and there, but for practical purposes, we have three causes for stroke, and a cardiac or a heart problem is one of the three causes of stroke, which is why I am one of your speakers today. So atrial fibrillation is a heart issue, which leads to clots in the heart, and then blood clots float off. And it's they could go elsewhere in the body, of course, but because the first arteries that they have a chance to go into are the carotids, that's where they go most frequently. It's kind of a straight shot, actually, as it comes out of the blood, out of the heart, for the clot to go into the carotid arteries. Now, the heart has its own rhythm. The normal rhythm gives off which has a name, it's called sinus rhythm, is a very coordinated rate, is around 60 to 70. The upper chambers beat, followed immediately by the lower chambers. And then the upper chambers have a good forceful contraction, so the blood inside the upper chambers is emptied and transmitted to the bottom chambers. Now, atrial fibrillation, that's a nerve problem of the upper chambers of the heart. I don't mean nerves like the brain cells, that type of thing, although it is technically nerve type tissue that's in the upper chambers of the heart that causes AFib. But mainly I'm trying to make the distinction. It is not blocked arteries giving atrial fibrillation, and it is not heart attacks or heart failure giving atrial fibrillation. It's its own problem. It's a primary nerve problem of the upper chambers. Actually has a genetic cause mainly. It's a fairly common heart rhythm problem. So in people age 70 to 80. It's around 10% of the population over the age of 80. It gets into the 15 to 20% of the population will have atrial fibrillation. So it's a common heart rhythm problem. When the upper chamber atrial fibrillation rhythm takes over, rather than the upper chambers contracting with a forceful contraction, the upper chambers start beating very fast, like 300 beats per minute. And the blood tends to basically pool in the upper chambers. It will find its way to the lower chambers, but it's not being ejected actively, okay? And so that's sort of the setup for the clot to be formed, which can then travel off and cause a stroke. So we have 3 sets of causes for stroke, and then the one that we're focusing on here is atrial fibrillation. So now, once we identify a patient who has atrial fibrillation, they may not have had a stroke, but we know from several large studies that the risk of stroke is high. It's going to be in the range of 5% per year, up to even 10% per year, sometimes higher, for the majority of people that we see this in. So this would be in your typical 70, 75-year-old individual who has some history of blood pressure, diabetes, or some vascular disease. It will be lower if they don't have those risk factors, but still it is at least around 5% per year. So the treatment, luckily we do have a treatment, is a blood thinner. And the time-honored one, older, is warfarin or Coumadin. And that was used for years. The advantage of that medicine, it's inexpensive. The downside is that it has a therapeutic window. So 5 milligrams for one patient is not the same as 5 milligrams for another person. It depends on their diet, their liver function, and so forth. So we have to check the blood test to make sure that the amount on the dose is correct. And then therefore, what that leads to is periods where the Coumadin is not at the proper dose. And during those periods, the patient is not getting protection. So the studies all showed that warfarin was very effective, but
good to know. Thank you.
when we had the market development of newer agents, one is called Eliquis, the other is called Xarelto, and then there's a third one, Pradaxa. Those have proven to be more effective than warfarin because they don't require any blood testing to prove how well they're working. Okay, so in 2022, the majority of our people are taking a blood thinner, one of those 3 medicines. And so what that then does is it thins the blood and it reduces the risk of the blood clot forming down to 1% per year rather than 5% per year or higher. Now, that sounds very good, but then when we do actual observational studies, it turns out that around 1/3 of patients, they're not taking the blood thinner all the time perfectly. They're not taking it twice a day or once a day like they're supposed to. And one of the common things that come up are sometimes it's major bleeding. So a patient gets hospitalized with drop in their blood count or some blood, either some lower and gastrointestinal bleeding, that would be common. Or sometimes it's extensive bruising. So I will have patients say, what I do is I take it on Monday and Wednesday, and then I give my body a rest the rest of the week to let the bruises go away. Then I take it, the next week. And so the idea there is that the blood thinners, they're very either on or off. So either you're taking it correctly or you're not getting any of the benefit. So it's fundamentally different than like a blood pressure medicine. If I take half of the dose of my blood pressure medicine, I am getting half of the benefit of lowering my blood pressure. But for the purposes of stroke prevention with atrial fibrillation and blood clots, if you're taking half of your Eliquis dose, you're getting 0 of the benefit, unfortunately. So it works out quite differently. So it's either all or none phenomenon, take it correctly or don't take it. So that creates this big clinical dilemma for patients who either cannot take blood thinner by absolute reason. For example, they had a major hemorrhage, or they're having major quality of life issues. They're bruising too much. They're having side effects. And so the studies all show that around 30% of people don't take it correctly. And that created the need for a different alternative to protect patients with atrial fibrillation from stroke. And I'll spend the next 5 to 10 minutes talking about a procedure, which the technical name is left atrial appendage closure. And the most commonly used device for that is called the Watchman device. So it's like your wristwatch, Watchman, and they have a very good website. So after this talk, you can all go and familiarize yourself with that. So when we look at the upper chambers, let me get this in front of the screen. Perfect. Okay, so we have here a model of a heart. The top chambers are the atria. Okay, now, and the lower chambers are the pumping chambers, the ventricles. Now, when the blood is pooling from AFib, the blood that's in the main chamber is not at risk. That blood will ultimately float into the bottom chambers before clot form. But there is this area hanging off of the upper chambers called the appendage. Let me see if this comes out. No, it doesn't. Okay. And the appendage is the vulnerability. So the blood can get caught into this area, and then it can get stuck here. And that's where the blood clots form. In fact, over 95% or more of blood clots that form in the upper chambers from AFib, they all form in the appendage. So the corollary of that is when you're taking a blood thinner to prevent a stroke, you're thinning your blood in your whole body, but you really only need it thinned in one area, the appendage. So the thinning the blood in the rest of your body doesn't do anything to help you. In fact, it's a little bit of a liability. It's a risk. Now, so the blood thinner thins the blood and it prevents clots in the appendage, and the efficacy is there. But as we said, there are around a third of the patients won't be able to take it. So there has been this procedure called Watchman. And what we do is it's a catheter-based procedure where we go in through the vein of the leg, the femoral vein, and we use a catheter-based delivery of this device, which will be inserted into the left atrial appendage, and it will close off the appendage. And that's what we're showing here. This is the device fully deployed in the appendage. And once it's here, then the blood cannot get in there anymore and form a clot. And the studies all show that we can reduce the risk down to the equivalent risk of being on a blood thinner. So the best way to look at this is if you have a Watchman, then you have the exact protection against a stroke as if you were taking a blood thinner, but then you don't have to take the blood thinner. So this is the catheter that we talked about. We go in through the vein, then we go inside the heart. And then when we get over to that appendage, we deploy the device. And then once it's there, we can release it. Michelle, I'm getting a lot of feedback from somebody has to turn the mic off. I'm not sure what's up. Okay, we fixed the problem, I guess. Okay, so that's what the Watchman device is. So again, you can imagine we go in through the vein and we get up into the heart, and then we image the appendage. Everybody's appendage is different. So we have 5 sizes of this Watchman, believe it or not. We size it so that this device can then be deployed. And then once it's there, we release it with this catheter. We take the catheter out, and then the Watchman's in place. After that, the patient is protected from the risk of stroke. And we continue the blood thinner in many patients for up to 6 weeks. We will not use blood thinner at all in around 30% of patients because they can't take a blood thinner. And so this has been one of the exciting areas of stroke treatment. So in summary, one of the three major mechanisms for stroke, atrial fibrillation, is aggressively being looked at in patients who are at risk of stroke. If you have one stroke, you have a 50% risk of a second stroke. So we're looking at anybody who's had a previous stroke, and then anybody with atrial fibrillation, we know that they have a risk for stroke. So we want to protect them. First line of therapy is blood thinner, but we have a very large pool of people who, for multiple reasons, are not going to be good long-term candidates for blood thinner. For those patients, they used to be sort of sitting ducks, if you will, at risk of stroke, nothing we could do, or we would keep them on blood thinner and then they would keep having problems. Now we have a good solution, this left atrial appendage closure with the Watchman. This procedure takes under an hour. We do it under general anesthesia right now, but in the future, this will be done with just sedation. There was a comment that that's a large sheath. That is, the size of it is 14 French, roughly twice the size of the catheters that are used to fix arteries with stents, for example. So, and one of the complications is bleeding at the access site in the groin where we put it in, and that risk is around 1 or 2%. So it turns out not to be very high. So we get away with this size of a catheter without any complications, with minimal complications. The risk of major complication under 1%. So this procedure has a around 99% success for closing the appendage successfully and letting a patient come off the blood thinner with low complication risk, and is an exciting new area for us. With that, I'm going to pause, and I'm happy to take any questions on the subjects that we've covered. We got a good 10 minutes or so, and I'll open up the floor at that point.
Okay.
Let
Thank
Sarah lead the charge here.
Yeah, okay, I'm gonna stop the recording.
Mhm.
So